We're going to hear many lessons learned from this second, speaker that we have this morning. Dr. Peter Jones really needs no introduction to you. That's his specialty. His specialty is hyperlipidemia and risk reduction. He's associate professor of medicine at Baylor College of Medicine, a longtime friend, and really is an expert on hypercholesterolemia, statin therapy, and he will enlighten us today about managing cholesterol, statins, and beyond. Peter, it's great to have you here today.
Yeah, thank you, Bill and Dr. Shah, for asking me to be here today. Yeah, my career has been in preventive cardiology, actually in the lipid field for 35 years. I was in it before it was even a cool thing to consider doing. But I do want to say that my presentation is, I hope you can follow it along if you have it live, because I've got a lot of information, and I hope that you will go back and review it afterwards, because there's a lot I'm going to say, but hopefully you'll be able to keep up with it. First of all, cholesterol is causative of atherosclerosis. There's no question about it. I think, and hopefully you know that genetically elevated LDL cholesterol causes coronary heart disease. We know that from Mendelian randomization studies. And the higher your LDL, the greater is your risk of cardiovascular disease if you inherit that tendency. And you can see that that's the case. These are genes that are related to elevated LDL across the bottom down here. And if you lower LDL, you reduce your risk of heart disease. There are people who inherit low LDL, and they have lower risk of heart disease. We know that if you intervene later in life and try to lower cholesterol, yes, you do reduce their risk of heart disease, but it's nowhere near as much as you would get if you inherited a tendency for lower LDL or had inherited a tendency for higher LDL. It's because of your lifetime burden of exposure to these atherogenic lipoprotein particles. So no question LDL cholesterol is causative of cardiovascular disease. You heard a little bit earlier from me about where we are with managing cholesterol. These are the ACC-AHA guidelines that came out in 2013. I will tell you that they will be updated and they will be presented in the fall at the annual meeting of the AHA in November. So there will be an update, the 2018 update. I don't think it'll be much different than what I'm going to tell you today, but it probably will include some of the factors I'm going to talk about in more detail than they did in 2013. But there are 4 statin benefit groups from randomized clinical trials. Hopefully you know them, and they're straightforward. Patients with established cardiovascular disease is group 1. That's called secondary prevention. Yes, all of them need to be on a statin, and it's regardless of their baseline LDL cholesterol. The other groups are actually primary prevention, group 2, 3, and 4. These are patients with genetically elevated LDL cholesterol. We usually call those familial hypercholesterolemia. Their LDLs are high. They're high their entire life. Most of the time it's single gene defects that cause that, but it can be polygenic. But they have high LDL for their entire life and early premature coronary heart disease. Group 3 and 4 are patients who are over the age of 40 with diabetes but no cardiovascular disease who have an LDL above 70, that's group 3. And group 4 is really pure primary prevention, as was presented in the case in the earlier thing. No diabetes, no cardiovascular disease, over the age of 40, whose LDL cholesterol is above 70, but you have to have a higher risk for cardiovascular disease, and that's the 10-year risk. Now let me just give you my thoughts about this risk cohort equation, which you heard about. Yes, it is derived from populations, and really good populations, but here are the entry criteria. So what does the entry tell you? Well, unfortunately, it doesn't help with the kind of diversity most of us see in our practice. For instance, race, you're either African American or you're white. Now, that doesn't help very much. And sometimes that does underestimate coronary heart disease if you put white in for Asian Americans or you put it in for Hispanics. It does underestimate their cardiovascular risk. The lipid component, I want you to see, you enter a cholesterol and you enter an HDL. Well, wait a minute, where's the LDL? Isn't that the bad part? Well, actually, the bad part is here. What does total cholesterol and HDL tell you? If you subtract HDL from total cholesterol, you have non-HDL cholesterol. This is the total burden of atherogenic lipoproteins. So you're actually entering all of the bad lipoproteins by entering total cholesterol and HDL. I do want you to remember non-HDL is a good predictor of cardiovascular disease. Now, it calculates 10-year risk. These are hard endpoints, but it also, this calculator will, and I've given you a way you can get it down here at the bottom, it does give you lifetime risk, and this is helpful for younger patients who may have family history. You know, their short-term risk isn't very high, but their lifetime risk is higher. And you may want to talk to some of those patients about a longer-term strategy for preventing cardiovascular disease from a lipid standpoint. So here are the 4 basic groups again, in order from 1, 2, 3, and 4. And what you're supposed to do is, if patients fit into one of these categories, yes, they are statin candidates. But the important part of the 2013 guidelines was to use appropriate intensity statin. Now look, I've been in clinical practice over the years, and I know what most of you do. Oh yeah, I'll give you a statin, I'll start low, and if you tolerate it, I promise I'll go up on the dose. Oh yeah, you all go up on the dose, don't you? No, they tolerated the lowest dose, keep taking it. No, what they're going to do here is give them what they need. If they tolerate it, fabulous. If they don't, then you can negotiate maybe a lower dose. We'll talk about that later. So the intensity of statin is really important. So the higher the risk of the patient, the higher the intensity statin. I'll show you what the intensity statins are in a moment. But high intensity for group 1 and 2, moderate intensity can be considered for group 3 and 4, except maybe more complicated type 2 or type 1 diabetics who may have end organ damage and so forth. But high intensity statins should be for the highest risk patients. Now, what about patients that don't fit into one of these benefit groups? You just had a case presentation. So patient presents and says, okay, I want to know what's my risk. Well, your risk is less than 7.5%, your primary prevention. You don't fit into any of these groups. What should I do? How do I tell you whether you have a risk or not for cardiovascular disease? Well, there are other things to consider, one of which was nicely presented about the coronary calcium score or ankle brachial index. I don't know whether any of you do that in your office. But there are other characteristics that can determine a discussion between you and the patient about a long-term strategy for prevention, including that lifetime risk, family history, maybe a polygenic, not necessarily single gene defect, elevated LDL, but some patients do inherit tendencies through multiple genes for high LDL, and inflammation. And I do want to point this out because patients with chronic inflammatory diseases have higher risk for vascular disease. That includes rheumatoid arthritis, lupus, psoriatic arthritis. They have a long-term risk of heart disease and a short-term risk of heart disease, and you do need to keep them in mind, even though they may not fall into a risk calculator. It may be somebody to consider discussion. The National Lipid Association also has these other risk factor indicators, and what I want to tell you is it's basically the same, but they do make a comment about lifetime risk. They do talk about severe disturbance in any single factor, such as very resistant hypertension to manage, people who smoke a lot or have smoked ever since they were 15 years old. There are other factors that may be considered as higher risk individuals. We also like lipid measurements as well, since it's the National Lipid Association. High lipoprotein a, that is a genetically determined lipid particle that increases risk of aortic stenosis as well as vascular heart disease. And very high alternate measurements of atherogenic lipoproteins such as ApoB can be considered. Also, chronic kidney disease, don't forget that, not just an eGFR that's low, but the presence of a high ACR, albumin to creatinine ratio, does increase over time patients' risk for cardiovascular disease. Here are the statin intensities. The high intensity statins are atorvastatin and rosuvastatin, and their doses are 40 to 80 of atorva and 20 to 40 of rosuva. That's high intensity statin. Moderate intensity are the rest of the 7 statins at less than those doses. So those are your options for moderate intensity. And here's lower intensity statin, which you get to consider if patients have tolerability issues, you might want to use a lower intensity. But patients should at least be high intensity to moderate intensity. You expect to get at least 50% or more lowering from high intensity, 30 to 50% out of your moderate intensity statin. So my conclusions about risk assessment in deciding on your patients: number one, the higher the risk per year for a major acute coronary event, the greater is the absolute benefit. Okay, so if you have a 10% 10-year risk, that's an average 1% per year. 20% 10-year risk is 2% per year. So the higher the risk, the greater the absolute risk reduction. So a 30% lowering of 1% per year is not as good as a 30% lowering of a 2% per year. okay? So who are the highest risk patients? Well, they're going to be patients with established cardiovascular disease who have other factors. Diabetics with cardiovascular disease, they have other lipid abnormalities, genetic LDL, high LPA, chronic inflammation, or uncontrolled LDL cholesterol with cardiovascular disease. They tend to have even higher events than you consider. For primary prevention, I like the lifetime risk for some patients. You can count risk factors. You can use these other markers, like I said, renal function, coronary calcium, to help you assist in decision. And for younger patients who tend to have probably high LDL from a genetic standpoint, if you want to measure genetic testing and they have a single gene defect, the whole family needs to be screened. They have a high lifetime burden of risk, and they should be treated as early as possible because they have very high early premature coronary heart disease. Now, talking about statin intensity, I do want to tell you that there are some patients who will not get the anticipated response to a statin. So if you follow LDL, you give them 40 or 80 of Atorva, and they come back and their LDL goes down 20%, you'll say, geez, you're not taking your drug. True, that's a possibility, but it could be, and they have a variable response. And I do want to show you that this was very interesting from the Jupiter trial. This was 20 milligrams of rosuvastatin given every day in a clinical trial, so patients were on the drug. Look at this waterfall plot for LDL lowering change to 20 milligrams of rosuvastatin. Half of the patients, you'd expect at least a 50% lowering. Half of the patients got 50% or more. That's why 50% is the mean. The other half didn't get that. And interestingly, about a third of the patients got less than 40% lowering in LDL. Some didn't even get any lowering. So there is a variable response to statins in some patients. And, as you might expect, that is genetically determined. And high Lp(a), the LPA gene, has the largest effect on low statin responsiveness in lowering, but there are other genetic defects that we have determined. So if your patient does take the medicine and they don't get the response, it's nice that they're adherent, but don't blame them. Say, okay, we got to find another way to lower your atherogenic burden. Statins don't appear to be it, maybe from a genetic standpoint. So what are the other alternative measurements or treatments that you have to lower atherogenic lipoproteins beyond statins, moderate or high intensity? Well, one is ezetimibe. I think you know that as the branded drug Zetia. So ezetimibe was studied in the IMPROVE-IT trial as an add-on to patients who are on optimal statin treatment in a secondary prevention trial. Ezetimibe lowered LDL from 70 down to 54. And over 7 years, that lowering, that difference, additional LDL lowering, in patients with established heart disease did reduce their future risk of coronary heart disease events and stable heart disease. Now, over 7 years, that was about a 7% overall reduction in cardiovascular risk, but the absolute risk reduction was 2%. That gives you the number needed to treat of 50 in order to improve cardiovascular outcomes. So adding a non-statin to further lower atherogenic lipoproteins did produce additional benefit. So ezetimibe has a role for additional LDL lowering in selected patients. The question is there any other non-statin drug to lower atherogenic lipoproteins? And the answer is yes. Now this, if you can say the words here, you come out today, PCSK9, some of you may have heard about. The name is actually proprotein convertase subtilissin kexin 9. It regulates LDL receptor expression. Now, statins work by increasing LDL receptors in the liver. They do that by inhibiting cholesterol synthesis. And the LDL receptors go out there and they attach to LDL particles and they internalize them, and then they get recycled to the surface and take more LDL in and so forth. Statins increase that LDL receptor. PCSK9 is actually a brake on the LDL receptor. What PCSK9 does is produced by the nucleus, goes out in the plasma, it binds to the LDL receptor, and instead of allowing the LDL receptor to be recycled, it causes it to be degraded. So it's a brake to make sure the body doesn't overexpress LDL receptors and overaccumulate cholesterol within the cell. So it sort of moderates LDL receptor expression. So that's why statins are limited in how far they can lower LDLs, because PCSK9 goes up. Well, if you give a PCSK9 inhibitor, in this case a monoclonal antibody, that binds to PCSK9 in the plasma and inhibit its effect on the LDL receptor, then you get more recycling of the LDL receptor, further lowering of LDL, and that was a process that really came to fruition from discovery to actual clinical usage in 15 years, which is a really quick movement in pharmacology to get a target to clinical usage in as little as 15 years. So the monoclonal antibodies to PCSK9 have been looked at in outcomes trials. And the first one was Fourier, and this was stable coronary heart disease patients, about 28,000 of them. They all had to have an LDL above 70 on maximal statin, and the mean LDL for these patients was 92 after maximal statin. They got randomized to take either, in this case, evolocumab or placebo. And the trial was completed after a little over 2 years, 26 months. The mean reduction in LDL was from around 90 down to around 30 to 35 milligrams per deciliter. And over 26 months, that absolute reduction, almost 60% and 56 milligram per deciliter reduction in LDL, translated into a 15% reduction in cardiovascular events, but more importantly, in 26 months, led to a 2% absolute risk reduction in cardiovascular events. So the number needed to treat was 50 there for a little over 2 years. Just recently, the Odyssey outcomes trial was presented at the American College of Cardiology meeting in March. This was the second monoclonal antibody to PCSK9. This was done in patients post-ACS, about 18,000 patients. Again, mean LDL on optimal statin treatment was a little over 90. The mean LDL reduction was about between 50 and 55 milligrams per deciliter. Mean percent reduction, about 55% reduction from baseline. This trial lasted for 33 months, got the same 15% reduction in cardiovascular events with an absolute risk reduction of 1.8%. Again, a very significant reduction. Mean LDLs down around 40 milligrams per deciliter in this population of patients. So these two drugs reduce cardiovascular events, lower LDL very substantially on top of optimal statin treatment, and appear to be safe, at least in the short run. So the expert consensus decision pathway last year in the Journal of the American College of Cardiology came up with how do you use these drugs in the 4 statin benefit groups? Let me just say that using ezetimibe can be used in any one of the 4 statin groups for additional LDL lowering. PCSK9 monoclonal antibodies should be given to group 1 and 2. That would be patients with established heart disease or patients with familial hypercholesterolemia whose LDL cholesterol still remains high on optimal statin treatment. The National Lipid Association says the same thing. ASCVD, progressive ASCVD on optimal statin treatment should be considered for PCSK9s, or any of the patients with familial hypercholesterolemia can be considered for PCSK9 treatment. No one else should be considered ASCVD or familial hypercholesterolemia. So when you use them for those 2 groups, first of all, maximize statin treatment, get their LDLs as low as possible. If that is not attained, LDLs less than 70, with patients with established heart disease or less than 100 with familial hypercholesterolemia, then you can consider ezetimibe if you need lowering of 25% or less. If you want a lot of lowering, then the PCSK9 monoclonal antibodies will give it to you. Are statins safe for everyone? Yes, they are. Don't let Dr. Google allow your patients to tell them what's wrong. Okay, so let me just say, a great review of this in the European Heart Journal just came out in April about the safety and adverse effects of statins. Yes, there are adverse effects that can happen, and the most common is statin-associated muscle symptoms and new onset diabetes. New onset diabetes does happen with high-intensity statins, but it's in predisposed individuals. They have insulin resistance, metabolic syndrome, and all statins probably do is push them a little quicker to diabetes than would have happened anyway. But if you don't have any of those predispositions, statin does not cause new onset diabetes. The rest of these things, cognitive, hepatic, renal, hemorrhagic stroke, cataracts, erectile dysfunction, none of that stuff is related to statin use. So it's all reviewed. I encourage you to go look at it so you can talk to your patients about it. They are safe and they should be used in appropriate patients. Statin intolerance usually is due to muscle symptoms, primarily, that's what you're going to get. Try non-statin treatments, ezetimibe, bile acid resins, PCSK9s can be used if they will not or cannot tolerate a statin, but do not forget alternate day dosing. We have patients who take rosuvastatin once a week. They'll take 10 milligrams Monday, every Monday. Some will take it 3 times a week, Monday, Wednesday, Friday. They'll tolerate that. Some will take it every other day. Find whatever you can. Any statin is better than no statin if they'll tolerate it. Also, please try all available statins. That includes pravastatin, fluvastatin, and pitavastatin. Those are really well tolerated, and pitavastatin like comes in 1 milligram, 2 milligrams. I trick patients. Oh yeah, you couldn't tolerate 10? Let me give you the 2 milligram one. And they go, oh, okay, and amazingly they tolerate that. So it gives you the same LDL lowering as 10 of atorvastatin, but it's 2 milligrams, so they get tricked. CoQ10 doesn't usually help. You can try it, but it usually does not. But very low vitamin Ds probably don't tolerate statins for muscle symptoms, but if you elevate their vitamin D, they usually can, so keep that in mind. Take-home messages, always prioritize your risk assessment, especially in your older patients. Use appropriate statin intensity, please, appropriate statin intensity, and you can always go down on the dose if you need to. Make sure that you reduce the atherogenic lipoproteins, LDL and non-HDL, and follow them. They're directly related to your risk reduction. The lower, the better, and I may add to that, the longer, the better. So if you start earlier in life, that probably helps as well. And non-statin treatments are helpful and provide incremental benefit in the highest risk patients, and I think I went over them, ASCVD and those with familial hypercholesterolemia. Thank you very much. Appreciate the opportunity.